Thank you so much, Philip. And it was really, really interesting. Of course, who doesn't want to live healthier and longer? I don't say forever, because with the forever, there are discussions still. And our last panel today, as part of the Global Webit Impact Week, particularly day 4, impacting the health and featuring health innovators, is a panel discussion on equity, inclusion, and diversity in the healthcare sector. And this is so important as equity, inclusion, and diversity in the society in general. But now today we're talking about health innovators, and that's why the healthcare sector is so important. And we have someone who is most probably one of the most experienced and absolutely suited to moderate this discussion. I have the pleasure and honor to welcome Jayne O'Donnell as a moderator of the panel. Hello, Jayne.
Hello, my name is Jayne O'Donnell. I'm so excited to be here today to moderate the panel on equity, inclusion, and diversity in healthcare. I was a reporter for USA Today for 28 years until April of this year, when I decided to focus. I was covering health policy, I should say, for the last 8 years, and before that, business. But I have been working for the last 5 years in an area directly related to this, where I've been trying to bring more equity to the media, more inclusion, more diversity, trying to bring in more young people of color to the media, the multimedia, all different aspects of it, because it's a lot more than newspapers now. So it was so exciting to be asked to be able to work on this. When we're trying to, just briefly, I just want to mention that with my work, I'm finding at very young ages that young people of color, particularly the ones that I'm working with from low income areas, there's a big distrust of the healthcare field, of the medical field. So trying to help them understand why things happen the way they do becomes so important, and seeing people that look like them is so important. And it's the same in the media as it is in healthcare. So the people the two women we're going to talk to today, and I'm thrilled it's a little bit more of an intimate conversation, are Aerts, it's pronounced Aerts, who's the head of the Novartis Foundation internationally, and Dr. Roopa Dhatt, who's a neighbor of mine, so to speak, in the Washington, D.C. area. And Aerts is based in Switzerland. Dr. Dhatt is executive director of Women in Global Health, and she's internal medicine hospitalist, I believe, at Georgetown University Hospital, and a professor downtown. So we're going to just go straight into questions. We just basically want to hear. It was so interesting to me, Anne, and you said I may call you Anne.
Sure.
But you're focused so much on urban areas, and that's where certainly where Roopa and I are based, and at least we're focusing, our immediate focus is. Like what is the Novartis Foundation doing right now to bring more healthcare to urban areas, to improve the quality of healthcare, and what kind of ways are you doing it? There's so much talk in this country, of course, around community health workers and people who really look like the people they're serving. But please tell us what you're doing.
Thank you, Jayne. Yeah, with pleasure. So the Novartis Foundation focuses really on how we can advance data, digital, and AI-driven solutions towards improving urban population health. And we do that around the world. So we have both at the policy level, we have initiatives, but our main programmatic initiatives are running currently in Sao Paulo, Brazil, for example, Dakar, Senegal, Ulaanbaatar, the capital of Mongolia, and also Ho Chi Minh City now in Vietnam, where our work on data and understanding the root causes of inequity in city populations is based in higher income cities where there's more data available, such as with New York City, with Helsinki, Lisbon. We are working to develop insights that can help us understand the underlying determinants of health inequities. But in these programs we are running on the ground in Sao Paulo, for example, our main goal is really working with local authorities, so the local city authorities, the mayor and his teams are co-developing these interventions with us that are focusing on what that city population needs. So we look at the available data, and then we design the interventions that can remediate the gaps in the health system, but maybe the gaps are also lying in other systems, like in the food system or the access to physical exercise or the school education. So we decide together with the local authorities where we want to put the accent or the focus of the interventions of these cardiovascular population health initiatives we run around the world. And they are very successful. If I can, I would give just the example again of Sao Paulo, but it's exactly the same results we measure in Dakar and in Ulaanbaatar. In only 1 year of intervention of such a locally driven initiative that is completely data-based, so you follow the real world data or the real time data, and you build your interventions on those. In 1 year of implementation, we could triple blood pressure control rates in cities such as Sao Paulo, which translates into a reduction of 13% of strokes in the population. So it's a massive impact you can achieve if you use data and you use an equitable approach towards population health, which means widening your lens for only healthcare to looking at the real comprehensive needs of a population at large, such as the 16 million of Sao Paulo, for example.
Could you just talk just for a moment? What was done to reduce the incidence of stroke by 13%? Like in a nutshell? Like
we focused on the control of blood pressure. So people living with high blood pressure, that's the main reason for doing acute events such as heart infarctions and strokes, but specifically stroke is very related to hypertension or high blood pressure. And when you control that better at the population level, you have immediately a large population health impact, I would say.
Roopa, when you think about what Anne just said, and how like closing the gender gap and also using data, how, like what does it bring up for you that, you know, how it would help? If it would seem to me, of course, I shouldn't say of course, but in my case, I often think of, I'm not thinking as much about the data as the people that are face to face, the community health workers. Like we need women, more women on the front line to be talking to women, to convince women. But what does it bring up for you, what Anne just brought up?
Yeah, so I mean, remarkable results there. So again, kudos to Anne and Novartis Foundation, but just sort of going a bit further with this, when we take a look at access to new technologies, especially the digital divide based on gender, women are less likely to have access to digital technologies, and that does play itself out in health inequity. So, one area that I would be keen to hear, and I'm sure the Novartis Foundation is clearly looking at these issues, is how to make sure that technologies are getting into the hands of women. And this means women health workers, as you alluded to, Jayne, but also, women are responsible for driving health in their communities, especially in their households and in their extended family, extended community. We did a report recently with the Find Diagnostics last year about getting testing into the hands of women. And in our report, in our initial overview, we did see a large gap in women healthcare providers, but also women in their community communities not having access to the tools that they need. And when they do have access to the tools, not the ability, the autonomy to use those tools or being empowered to use those tools. So any effort as we are trying to integrate and advance the digital technologies, use AI, we must be looking at it from a gender lens, doing gender assessments up front about who has access to these tools, how are these tools being designed, how are they being used, and whether or not these tools are effectively reaching health conditions that impact women specifically, such as hypertension. Clearly, that is a universal issue, and women do have a significant burden of heart disease, stroke, high blood pressure. So from that perspective, it clearly is a universal health issue for women, but looking into specifically how are women able to engage with this technology.
Mm-hmm. Yeah, very interesting. And I think about how so many young people tell me, or other doctors in the Washington area and elsewhere will tell me that so often men don't go to the doctor unless their woman insists that they do so, or there's certain other problems that they have that are of more interest than others. But I'll leave that.
And Jayne, I was going to say, just, an example of even introducing technology. Sometimes it's not as simple as getting access to a digital technology such as mobile phone and mobile tech. In times when new technology is introduced, it can change the power dynamics in a household. And there's been studies that have shown that when that transition is initially taking place, women might face more increased gender-based violence because of the power dynamics changing if a woman goes from not having access to mobile tech and then having access to mobile tech. So, when we are looking at really applying a gender lens and doing gender impact assessments, the entire, process of integrating technology into communities and getting into the hands of women requires that assessment.
Oh goodness, we could talk about domestic violence all day, but let's turn to COVID, which everything seems to relate to now. And when you think of, and to both of you, when you think of what we're talking about right here, what did COVID show us about the importance of everything we're talking about, and how important? Let's just hone in on AI. How important is AI? As we recover and hopefully come out of the COVID pandemic?
Yeah, Jayne, I think COVID has been showing us, or has been a real wake-up call to let us understand that our current healthcare systems are really not the ones we will need for the future, or we already don't need now. In fact, our healthcare systems are insufficiently prepared to address a big challenge like COVID. And this wake-up call makes us realize that we have to do things very differently. We have to really rethink the way we deliver health and care around the world. And our health systems have to become true health systems. And the best opportunity we have is to use the power of data and AI to do that, to transform our health systems from being these reactive care systems that wait for people to get sick, to get addressed with their problem, to become more proactive, predictive, and ultimately preventive, so that they can keep their populations healthy. And that is the future for our health systems, I believe. But we really need to tap into the power of data and digital technology for that, where I agree completely with you, Roopa. You cannot increase a digital divide by introducing digital technology. This has to be part of a real good plan where you do the things as they have to be done. So I think the whole ecosystem has to be ready. You need to have the skills, the digital skills in the people who will be equipped with the digital solution. You need to have the infrastructure, the connectivity. And by the way, COVID was a very good way to increase broadband connectivity around the world Nowadays, since the COVID, before the pandemic, almost half of the population was still unconnected in the world. Most of those people living in low and middle income settings, but now at least that percentage is reduced to 37% this year, apparently at the end of 2020. So a huge jump forward to get more and more people connected.
Mm-hmm. But at least
yeah. that is not going to be enough. You need to design your solutions for the people who will have to use it. As Roopa says, it has to take the needs of women and women users into account, as it needs to take the other needs, users' needs into account as well. I think the digital divide is definitely including women, yes, but it also includes a lot of other types of groups of population, like the aging population, or people with disabilities. And we have to look at take a holistic lens when we design and use these innovative technologies that can really help us transform. We really need to think well and integrate it with the proper processes. All what you mentioned, Roopa, is absolutely essential.
Roopa, when you address it, I was just curious if you could also touch on, it seems like the promise, if in fact there is promise in your views, of texting as opposed to full internet connectivity, if there could be more done with that to reach some of these hard to reach populations. But please go ahead.
Yeah, Jayne. And I wanted to just build a bit on what Anne was saying there, that there are huge gains to be made by using artificial intelligence. We know we can process data a lot more. We're seeing it with diagnostic testing of COVID-19 infections, but we're also seeing it with access to therapeutics and vaccines. There is a lot of discussions going on about how do we get vaccine equity within countries, but also between countries, and really harnessing the super intelligent capacity of AI is really critical to addressing those health inequities. And those health inequities go across a broad range, not just gender or geography, but as Anne alluded to, really using this intersectionality lens of, the minority groups, people with disabilities, aging populations. And so as a practitioner, as a physician here in the Washington, D.C. area, I saw firsthand as the COVID-19 pandemic was evolving that our data was also evolving, and that has a lot to do with the capacity of artificial intelligence and the data we were gathering. So we were able to find out which populations in the DC area, but also in the United States, were not getting access to testing, we're not getting access to therapeutics, and then eventually where there has been vaccine hesitancy or lack of access to vaccinations and vaccination misinformation. So that's been all very valuable. But going back to your question about the different levels of technology, so low-tech solutions, especially the texting apps, they've been really effective, and I'm sure Anne can comment on some examples of those from her experience and Novartis's use of that. But I have seen firsthand in the Women in Global Health movement that especially during this pandemic, we have had so many different WhatsApp groups form. Many of these are formed at the national level, where women who are working in health or connected to the global health field are exchanging knowledge, information, and resources, trying to connect with each other to mobilize when they weren't able to find their solutions in other places. And so we are seeing the surge of using platforms such as WhatsApp for knowledge exchange, resource exchange, and there's already been a legacy of mobile technology using texting as a means for patient engagement.
And so how have you seen that?
Oh, yeah, absolutely. Because in many areas of the world, even WhatsApp is not always easy because of the connection. So text, and even in illiterate populations, we use a lot of voice messaging. In Ghana, for example, we had a program around high blood pressure again, and we really used voice messaging to educate people on what healthy behaviors were for what kind of food and salt consumption you should stick to if you want to control your blood pressure better. And this really was very efficient. So text and voice messaging, of course, they are crucial. When I was a young physician in the beginning of my career, I was working in Africa in remote areas. In conflict areas, in fact, because I'm an emergency physician. So I was dropped by plane in the middle of the guerrilla areas, and I was going on my bicycle from village to village to see the patients they kept for me in triage to understand their problem. And I often came too late, obviously. Nowadays, you can do that with a simple phone call. You can guide community health workers on the ground through their patient care. You can increase access and quality of care massively. And that's all thanks to the power of virtual health services, in fact, and that during the COVID have bloomed. We've seen in many countries that it has been a 3,000% increase of uptake of virtual services, where other countries were left behind again. And there we come back to this inequity between countries, where currently we are performing with the Broadband Commission for Sustainable Development, another working group on health that I chair together with WHO this time. And we look at what were the enabling factors for countries that could increase their virtual health and care services massively during the pandemic, and what were the bottlenecks or the challenges in those countries where it didn't happen. And it wasn't only high and low income versus low income countries. There were very high income countries who didn't see this uptake either, because the regulatory and the policy environment was so rigid. So we are examining really what were the facilitating factors and policies that made it possible. And I think that's also a very important step forward in our post-COVID world, hopefully when we get there one day to the post-COVID world, of course, that we can use then to really get virtual services everywhere. But because that's the future of health and care, bring it closer to where people are, where people live, in their living room, or in their workplace, or in the shop, on every corner of the street, whatever it would be. So,
both of you work internationally, and I, of course, traveled internationally, but I don't. And I tend to think of, when I hear equal access to healthcare, I'm often thinking about the resistance to seeking healthcare, even when it exists. You know, since I've covered healthcare only since the Affordable Care Act came into being here. So I wondered if both of you, each of you, or either of you, I should say, could touch on what can be done to kind of, how can technology perhaps help people with their hesitancy, the word that's used all the time as it relates to vaccines. I mean, I've had so many conversations just in the last couple of months with people just who don't want to take blood pressure medicine. When you speak of blood pressure, to me, that seems like a no-brainer. I mean, is there a way, or does that really come down to communicating person to person with these community health workers?
Jayne, that's such a complex issue, and I think it is one we're trying to understand and unpack so much more about. How do you build trust in communities, and then build trust within populations and people at the bottom line of it? And then there's also the active effort of misinformation that's floating around, and there is a responsibility in the digital space to really look at how do we verify the information and make sure these are coming from verified, trusted resources. So that is an evolving space, and one that we do need to continue to look at and understand. But going to the first part, and I'll begin as a physician that has had to build these relationships from communities that have faced a lot of trauma and stigma, and have a historical legacy of having structural racism here in the United States, especially when we take a look at the African American Black population, or other minorities of different ethnic and racial backgrounds, what they have faced from the medical system. So contextualizing that, one, acknowledging that, two, having awareness of that as a provider. Too few providers have been trained with this lens of understanding why diversity, equity, inclusion is critical, and why we must address our unconscious bias. So at Georgetown University, where I currently practice, we do go through anti-racist training as part of our curriculum as faculty, which is fairly novel. It's not something that was around when I went to medical school, which wasn't too long ago, over a decade ago. So I think the first part is really providers understanding, and providers are not just physicians. This training really does need to get to nurses and midwives and community health workers, really understanding their communities and what issues, barriers that they have faced, and even some sometimes, the trauma that they faced, and really working with those communities. The second part that you alluded to, that you in your work that you do already, is that we need to have many more health providers that come from their community. So we need more women, but women from minority backgrounds, and we need to get the information and the technologies into the hands of these communities, but they must be also co-designed. They need to be seen as leaders, as change agents, and not just a vulnerable recipient population. And that's a lot of what Women in Global Health has been doing since we started in 2015. We say it's time to change the narrative, view women as leaders, especially women from underrepresented backgrounds. And one of the really exciting things that we actually were able to do, and it's great to have Anne on today's call, is that we linked up with Novartis Foundation last year, and we had an innovation challenge where we encourage women, especially from low middle income countries, to bring their innovation solutions forward. And our top candidates were from the global south, low middle income countries, and our very top winner of that innovation actually was working on maternal neonatal child health solutions as an app to increase health services. And that was created by a group of women from Nigeria, and they co-created this. And so again, this is an example where it's not an outside group coming to create the solution, but it is being created by people from a community, and that's all part of building trust. And the second part, which I alluded to already, is that understanding that misinformation is present, it is growing. It also requires us to have structured approaches and safeguards in place, and that does require a whole of society, whole of government approach to address misinformation holistically. Thank you.
And Anne, would you say that it is, I was framing it because I am thinking of it as one of the big health challenges, the disinformation, the hesitancy, but is it one of the biggest global health challenges, Anne, in your view? And if so, or if not, what other challenges are there that really seem somewhat insurmountable?
Oh, definitely. It is a global issue. Misinformation, lack of information, definitely. We see that a limited health-seeking behavior is very often in low and middle-income settings linked to the lack of knowledge about the risks, about the symptoms, or about the absence of symptoms, but the lack of awareness of the risks you run when you never have any checkup or we saw, for example, in Sao Paulo, where we introduced that everybody who would pass in the health center would get a blood pressure measured, regardless the reason, whether you're a caregiver or a mom or a dad coming with your kids. And we found with the follow-up of the data, the real-time data, we found we missed one group of the population completely, and that were the young men. So they never come to the health system, as you alluded to, Jayne, as well. Young men don't even want to go to the doctor. But what did we do? Well, we went to find them in the biggest football stadia of Sao Paulo. So we went to create that awareness in the football stadia. We offered screening opportunities in the metro stadia, in the metro stations, where people have to pass anyway. Because people are very busy getting a new job every day to survive. You cannot expect that they sit for hours and wait that they can have their blood pressure measured in a health center. So they have to get it done while they are on the move or where they pass. So we looked at what the high traffic venues are in the city, and then we found the young men there. So it's also a way of looking at what are the pain points in the system and what kind of groups are you missing. But I cannot agree more with Roopa that if we want to design innovative solutions for women, it has to be done by women. And I really love this challenge we had together last year for calling for women entrepreneurs for new solutions. And in fact, last week in Rwanda, we opened the first and the largest health tech hub in Africa, together with the Northern Foundation, which is a big investor in Scandinavian countries. So what we do there is we house several health tech innovators to further develop their innovative model and business plans so that they can scale it to many more people and get it to many more people who need it. So that being said, in that challenge, we specifically looked at those who had a gender balance in their company structure or who were led by women. And we are convinced that that is the way to do this. You cannot just exclude women from the tech sector, because in the tech sector, there's even it's much less than in many other sectors. And in the health sectors, it's mainly women, in fact, but in the tech sector, it's mainly men. So we have to get that balance straight. That's a very important point you made, Roopa. And lastly, let me say that also within the US, where we, for example, in New York City, are really looking at what drives these disparate or different health outcomes in different population groups of the city, we will hopefully be able to guide the decision makers in the city then to allocate resources to those groups that really need it most. And this is the power of data and computational power we have now. So it's in partnership with Microsoft we do this, and the city authorities, to really see if we can create the insights they need to understand who needs what kind of follow-up. Because currently there is inequity. It is a given in every mega city of the world, and including the US. Obviously, this COVID has put the spotlight on it. So every politician will have to address it or do something about it. And there, I want to end also by a great initiative of our Novartis US Foundation, which launched a pledge and a collaboration with the historically Black colleges and universities in the US for a very large program that will run over several years to include many more patients and investigators from those population groups, African American and other population groups, but also to create many more opportunities for people to start trainings in medical education from those groups. So we want to balance that the representation of all groups of the population are also represented in the health workforces. You said that's very important. I think it's really something that can be stimulated. And then make sure that in our clinical research that the company is doing, we get enough representatives from the investigators, so the real academics, and the patients of those population groups. So,
and that's a perfect segue to Roopa with and I'm so pleased that you brought up tech, because you do have to reach people, some of these young people as early as possible, and we find we're going to middle school from high school. Roopa, like when you think of the gender gap with women in healthcare, do you think about the tech side of it? And what do you think needs to be done? I mean, how big of a problem is it? And what do you think needs to be done to address that part of it?
Yeah, so really great to hear about the stuff, Anne, that the Novartis Foundation is working on. But definitely this, to give you like a picture of what global health leadership looks like and where women fall into this pyramid of leadership, I think is a really important one to talk about why we're still really discussing leading women in tech and particularly health tech and innovation. So when you take a look at the global health leadership pyramid and use this as a snapshot to reflect most countries in the world or regions in the world, about 70% of the health and care workforce are women. If you take a look at the social workforce, it's about 90% women. So really the base of the pyramid is majority women. And then when you start looking at who is leading academic institutions, deans of public school, public health schools, schools of medicine, or looking at political decision-making, ministers of health, or those representing decision-making at the global and regional level, those numbers tend to be stagnant around 25%. And then when you climb up to actually the private sector, healthcare companies that are part of the Fortune 500, you see women's representation drops down to about heading 5% of healthcare CEOs are women. And so when you look at that pyramid itself, it tells you a lot there already. When we break down the first part, the decision makers and those that are designing our educational institutions and are again led by men. And then when you look at the private sector, which is very exciting, very critical to achieving health goals in many communities, again, the decision-making power power score, skewed toward men. If you apply a lens of like where in the global health landscape are decisions being made, majority of these continue to be in high income countries, decisions being made for those in low middle income countries. So we are talking about in Women in Global Health and many other global health institutions and actors about how do we really transform power to be more equitable and get it into the hands of communities, and making sure that decision makers are from the background of the communities that are most affected on these health issues. And that's going to be critical. And women are a big part of that, but also women from a diverse range of communities as well. This pandemic gives you a prime example of how pervasive gender inequities are. And to give you an example from a policy perspective, so currently when you take a look at COVID-19 national task teams, Women in Global Health looked at over 115 task teams from around the world, 87 countries. We found that 85% of those task teams were majority men. There were entire regions of the world where their entire COVID-19 national decision-making body were completely men, even if they had 10 or 20 people. And the United States, for example, their first COVID-19 task team was all male too. So going back to this universality issue that Anne was also mentioning, gender inequities are pervasive everywhere. And that's impacted policies. So to give you an example, the WHO did an early survey of which services were disrupted during the pandemic, and on top line services that were disrupted were access to maternal neonatal care, family planning services. And again, I can guarantee you that if we had women in equal numbers, there's no way a woman would say that pregnancy stops during a pandemic. And it hasn't mattered whether you were in a country like Germany or Nigeria. Women have been told to give birth at home during the pandemic, especially in the early stages. And it just shows you that if we don't have women in decision-making powers, it influences the policies. And I can kind of cite many more, but just to say, we really do need to walk the talk and bring the perspectives of people that are underrepresented into decision-making roles. And that will lead to better health equity and better health outcomes for all genders.
And we have about 9-10 minutes left. I did want to go to the last question, but please do, I want to keep it conversational here. Is there anything you wanted to say in response to Roopa?
Oh no, I cannot agree more with all of that. This inequity in the decision-making power has to be addressed as well. Yes, absolutely.
This is you can choose to not address the specific point that comes up for me when I think about how will things change? How is it going to get hopefully more equitable and access to healthcare around the world in the coming years and decades? But there's something that comes up for me, and I just wondered you would touch on it, please, if you would. I think it was Anne that mentioned follow-up and the need for follow-up. But I hear, particularly when we're talking about Medicaid populations, and this was being talked about in Baltimore, but I think it happens a lot of places, that with a lot of the healthcare systems, and because we're not, I guess you could say, punishing, or we're almost rewarding hospitals still for doing more care for somebody. There's almost a disincentive to follow up because they think they're losing money, because the more Medicaid paid services they might have to do, that could cause them to lose money. If they have a limited, only so many patients they can see, they might go, practice could go to commercial pay or Medicare. But I'm curious if any thoughts on that. Will that get better? Are we going to get closer to a reimbursement system in the United States that actually addresses that?
Well, I cannot really speak to the US system, but what I can say is what is globally true. It's mainly the early detection of a problem that helps to advance the health outcomes. If you run around too long with a problem like diabetes and you don't get it addressed, you have already a legacy you bring forward for your outcome. It will never be as good as if you would have started your treatment from the first symptoms that you could have identified. So the early detection in all of our urban population health initiatives has been crucial So you need to give people access to having their condition diagnosed in time and as early as possible. That will prevent people to need hospitalization, to have acute events that need emergency care, and all of the heavy lifting costs for a health system. So
I was thinking, excuse me one second, I was just thinking about cancer, like with breast cancer.
Yeah, same.
Yeah, if they're not.
You know, in low and middle income settings, breast cancer is a death sentence, but in our countries nowadays, it's not anymore. If you diagnose your breast cancer early, you can very well survive for many, many decennia, where in low and middle income settings, it's simply always detected too late or in a stage that is much more difficult to get a proper treatment that gets you better chances. So it's absolutely the same for any kind of condition. You need to first and foremost address the early detection, but at the same time, in parallel, improve the quality of care, because that's a major issue around the world as well, and including in the US. We've seen in the initiatives we started in the US that standardization of the frontline care will improve massively outcomes immediately, because there's such a, I would say, a mentality, and that's a medical corps mentality. I have the same mentality from, we are doctors, we know what we have to do. So the standardization of frontline care delivery is massively beneficial as well, together with the early detection. And only these two can already make a huge difference around the world, including in high-income countries, in fact.
Roopa?
Yeah, so I agree with Anne from especially that clinical perspective there. But going back to really this issue of like, how do we achieve gender equity and broader equity in decision making in health sector? We really believe at Women in Global Health that's critical to achieving the health equity goals. And so what we call for Women in Global Health is we need to go beyond the gender parity and really make sure all leaders, regardless of which gender, so engaging men, and also institutions to be gender transformative in their policies. And that means looking at the root drivers of why gender inequities exist, addressing gender norms, and really making sure we don't leave anyone behind in leadership and decision making. And so we recently launched a 4-point action agenda of how do you really achieve gender equal leadership in the health setting. And so the first thing that we really ask is for governments to really create the legal foundation for gender equality to enable women to engage men equally at work. There are many governments around the world that still have restrictive policies that limit what type of work women can do or whether women can even take on night shifts. So that's an example where we need to really have a strong legal foundation of gender equality in every society. The second is really around addressing social norms. We touched upon this a bit with the potential of artificial intelligence and technologies. Currently most of them are hardwired with the same pervasive bias that exists in society. But if we actually harness and intentionally design artificial intelligence and other technology tools to address these root drivers of gender inequities, such as social norms and stereotypes, we really can accelerate and make progress on how we value women and how we value and view women as leaders. And one of the reasons that women in the health and care workforce have their current position of being at the bottom of the pyramid and not at the top level really is driven by the fact that women are undervalued and not viewed as leaders. And so the second is really around getting to the root drivers. The third that we really talk about is too often our interventions are focused on fixing women. So we will create programs to train women, to boost their confidence, for them to lean in, to learn skills such as negotiation. I'm just picking on these examples, but what we really need to be doing is investing in institutional change and address workplace systems and culture, and talk about power and how do we transform power and make sure power is getting into the hands of all people in communities that are especially underrepresented women, but also, as we've discussed, people from a broad range of backgrounds. And we need to stop trying to fix the people to fit into unequal systems. And finally, I'd say we have a responsibility to always look at how do we create an enabling environment for women so that their their perspectives are truly integrated and our healthcare solutions are being designed by them. The prime example of, cervical cancer, breast cancer, a whole range of women's health issues are currently underfunded, and testing technologies are limited there. We know that, if women were engaged a lot more and in decision making, they would be making sure that resources were getting to these funded areas. And going back to your question, Jayne, about the context of what's really needed, as a physician that practices in the United States, I'd like to say, I hope we will one day get to a place where we truly have universal health coverage that is the Sustainable Development Goal on health and well-being. It includes achieving universal health coverage by 2030 for the entire world population, so that no one ends up going into poverty because of their health needs. We are globally far from reaching that. Our systems are currently incredibly stressed. The health workers that we need, there's an 18 million health worker shortage. Majority of those are going to be women that fill those jobs. And right now there's a great resignation happening as women and other healthcare workers are truly burnt out. We're seeing that in here in the United States. But I really do hope in every society we are moving towards this pathway of universal health coverage. We're doing it truly in an equitable way, a gender equitable way.
Thank you so much. Anne, any final last succinct comments?
Well, I think this would be the beautiful equal world we want to live in. And I think we still have a long way to go, but we can do this with data and AI and with good policy making. For example, I live in Switzerland, and I was very happy to hear last week they voted here to increase the value for the nurses in the system, because that has been the main driving force behind the response to the COVID pandemic here in Switzerland. And I really liked it. So maybe that's my last word. But of course, in the world, we have a lot to do to value more women in the workforce, women in the health workforce specifically, and get more women in leadership. Yeah, we have to really push for that. I agree, Roopa.
And more respect for healthcare workers overall. They're so important these days, as we now know. Thank you so much, both of you, for being with us today. For more information.
Thank you.
Thank you.
Thank you. It was a very pleasure.
Thank you so much to all of you. Indeed, full respect to the caretakers and the healthcare workers for what they've been through, proving that their voice are real, saving people's lives while being challenged and threatening their own lives for the sake of others. Full respect to all of you who helped save so many people's lives in this, most probably one of the most challenging pandemics and which the humankind faced, at least for the past 100+ years that our memory has. Now, regardless of how much I want this to continue, I should say this is the end of day 4 of the Global Webit Impact Week. 4 days full of phenomenal, exciting, mind-blowing, eye-opening discussions, keynotes, and open panels. I can't say how grateful I am to every one of you who's been here with us, among the speakers, among the panelists, particularly the moderators who committed so much time and efforts and energy for making this such a great content. True appreciation to all of you, and of course to the phenomenal Webit team who is working around the clock with all different time zones in order to make this happen. Now, if I have to wrap up this day, it's been truly amazing to discuss how digital is shaping the future of healthcare, and having Elizabeth Breer from Forbes, with Natalia Jovanovic, Chief Digital Officer at Sanofi Pasteur, and Francesca Ludke, the Chief Digital Officer of Almirall. and further revolutionizing global food systems by agtech and food innovation. Nutrition is so important for our health with Frances Koo, correspondent and producer at CGTN America, along with the head of vegetables research and development at Bayer Corp Science, and Sam Kass, partner at AgriVentures Partners, founder at Trove. Further, we had a fireside chat, AI in healthcare, expectations, reality, and future. Ryan from CNN, Ryan Prior from CNN, a dear friend of Webit, moderated. The Vice President, Global Lead Data Science and AI Center of Excellence in Digital Division of Research at Philips. And we had a very deep dive into trends in healthcare innovation ecosystem, moderated by Jayne O'Donnell with John Nosta, Dirk Richter from Abu Dhabi Health Department, Mo Force, Head of Global Commercial Digital Innovation and Head Botanist at the Digital Garden, Almiral, Nicole Hill, Global Healthcare Sector Director at Alcatel-Lucent Enterprise International. And then we had Health Sciences and Technology, Unlocking the Actionable Knowledge. Again, Ryan was so kind to moderate, Ryan Prior from CNN, to moderate Dr. George Church, Professor of Genetics, Wyss Institute at Harvard University, and Dr. Stephen Wong, Chair, Professor and Chief Research Information Officer at Houston Methodist Hospital. We were hosting Daniel Kraft with his keynote on telemedicine during the COVID-19. And it was also a great panel discussion on advanced technology shaping the future of personalized medicine, with Elizabeth Breer being moderator from Forbes, and dear friends, Raphael Grossman, surgeon and educator and futurist from Raphael Grossman Health, and Professor Stefano Bini, founder and chair, Digital Orthopedist and Conference, and Professor of Orthopediatric Surgery, Professor Maki Sugimoto, co-founder at HoloEyes Inc. And it's been on and on and on. It's been such a pleasure to host you all here. We had a great keynote by Prit Banerjee about leveraging computer models and simulation to make you live longer and healthier. And we concluded the day with something that I really care about. I'm a feminist, you know, very well. So equity, inclusion, and diversity in the healthcare sector was a great panel moderated just now by Jayne O'Donnell with Anne, head of Novartis Foundation, and Roopa, executive director at Women in Global Health. Now, this is a wrap. Today's the fourth day of the Global Webit Impact Week, committed and focused on health innovators. Tomorrow is the last day of this 5 days of phenomenal talks and opportunity for all of us, 100,000 people from over 190 countries to network and to be inspired. Tomorrow, we focus on digital entertainment media. So if this domain is of your interest, don't forget to join us at 10:30 a.m. Central Eastern European Time. See you tomorrow.